Bronchiectasis is airway dilation and scarring. When we inhale, we have oxygen traveling down our trachea, our main airway, that then it bifurcates or separates into the left and right main stem, and then those airways progressively get smaller as it transitions out to the alveoli. There's a balance of the forces between the alveoli and the airways, and if the airways are weakened, there's more pull from the alveoli, and that dilates the airways. And that will impair the natural gradient or movement of the mucus up from the small airways into the larger airways. Cilia are microscopic hairs that line our airways, and they beat almost like a grain or a field of wheat. And so that coordinated movement will then sweep the mucus and particles up through the airway. In the setting of bronchiectasis, when there is excessive mucus and damage, the cilia can't beat effectively. Most of it is because they're kind of tamped down by this thick, heavy mucus, but also because of the widening, that coordination is just not sufficient to effectively sweep the mucus up out of the airways. We really don't know how or why some patients develop bronchiectasis. There are patients who have, again, underlying causes such as immune deficiencies or mutations in the cystic fibrosis gene, but for the vast majority of patients, we don't know why they develop it. There's probably an underlying predisposition, potentially from airway clearance, that maybe there's a bit more airway collapsibility, or that there's a very subtle change in the immune system that leads to this continued infection and inflammation. There are some tests that we will do to see if there's an underlying cause of their bronchiectasis, but even without knowing the cause, the treatment is the same from a foundational standpoint. Bronchiectasis patients can range in age from childhood all the way up to being adults in their 80s. Typically what we think of as idiopathic bronchiectasis, or those without a known cause, they tend to be older adults and in their kind of middle age or kind of retirement age even. We see a preponderance of women, but it does affect men as well. The symptoms often include a persistent cough. The cough doesn't necessarily have to be productive of sputum, but the cough exists because there is an excess of sputum, of mucus in the airways. Some patients will have wheezing. If you did breathing tests, you might see that there's some airway obstruction, and patients can be labeled as COPD even without a smoking history. They may experience shortness of breath or difficulty either having the breath or energy to do their usual activities. Exacerbations are acute worsening or flare of your underlying bronchiectasis symptoms. And we would define those as at least 48 hours of a change in your cough or mucus production, a change in your breathing such as wheezing, chest tightness, increased dyspnea. You can have a fever, but you don't necessarily need to. Hemoptysis, or coughing up blood, can occur. Oftentimes patients will feel more fatigued, that their energy is down, and again, this is sustained over 48 hours. There can be some variation in your sputum production and color throughout the day, but if it's changed, it's thicker, it's more profuse, and it's darker, that would very much be consistent with an exacerbation. The definition of the vicious cycle is that you have inflammation, and that then begets infection, that there's impaired airway clearance, and then additional mucus buildup. And so folks can enter that cycle in different places, but each part of it affects the next area. And if we don't break that cycle, you end up with further damage and destruction of the lungs. The foundation of treating bronchiectasis is to provide the airway clearance that your lungs would normally do. It's critical to get that inflammatory stimulus of the excess mucus out of the lungs, and that also decreases the amount of bacteria that are in the lungs.